Good evening. Tonight's discussion, the third in our Spring 2005 lecture series, focuses on the ugly cholesterol, lipoprotein A, and its physiologic antagonist, vitamin C. My name is James Roberts. I'm board certified in internal medicine and cardiology. I've been practicing invasive and clinical cardiology in the Toledo area over the past 19 years. I'm the medical director of comprehensive heart care, the EECP Center of Northwest Ohio, and the Advanced Magnetic Research Institute of Northwest Ohio. By now you've gathered that I'm quite interested in integrating the principles of nutritional medicine in with the principles of standard invasive and pharmacologic cardiology in which I was trained. And I feel if we take the best of nutritional medicine and merge it with the best of drug and invasive and surgical medicine, we get the best outcomes for our patients. So I recommend to all my patients and people who don't want to become patients antioxidant vitamins and minerals, essential fatty acids. We'll talk about vitamin C and lysine and proline tonight. And I might recommend some nutritionals with exotic names like ginkgo biloba or proanthocyanidins. Kind of a potpourri of biologically active herbs and spices, you might say. And this works for me. It works well for myself and my patients. But some of the other physicians in the area do not share my enthusiasm about nutritional medicine. They don't agree with what I'm doing. And some kind of roll their eyes and shrug their shoulders, and others might make comments about me that are not particularly positive. One doctor said, well, it's witchcraft. He's practicing voodoo medicine, voodoo medicine. But you know, these doctors haven't read the papers that I've read. They haven't been to the meetings that I've attended. And I don't think they've had the joy that I've had of seeing a patient who was hopeless and helping them turn themselves around and get their lives back. So this is working for me. I didn't always practice medicine this way. At one point, I practiced only standard orthodox cardiology. And you know, when I was 35, I was tied with two older guys as the leading admitter of cardiology patients to my primary hospital. There are 8 beds in the coronary care unit at that hospital. One Tuesday afternoon for a 2-hour period, I was managing all 8 patients. They were either mine or consults. So I was doing lots of invasive work on patients over and over. And the reason we were doing it over and over was because we weren't dealing with the causes of their heart disease. And then that changed for me when I got involved in integrative medicine, asking my patients to take nutritionals along with the drugs. And now, hospital admissions are few and far between. I'm seeing sicker people by virtue of my interest in ECP and MME, yet by taking this combined approach, integrating the best of nutritional medicine with what I think is the best of orthodox medicine, I'm doing a much better job of keeping people out of the hospital. So if the other guy's patients are spending more time in the hospital and mine are spending more time at home, I don't think this is voodoo cardiology. I kind of think that the recipe for this medicinal soup that we're serving up to you maybe was given to us by the great chef upstairs, who designed us to take in antioxidants and minerals and fish oils, etc. So, you know, if my patient's doing much better now than in the past, it's not voodoo cardiology. I prefer to call it deep magic cardiology. Deep magic from the dawn of time cardiology. Now, did any of you see the movie Shadowlands a few years ago? It was about the life of C.S. Lewis. Lewis was a British theologian. He taught religion and history at Oxford. He wrote a number of books about the relationship between mankind and his or her deity. But he's best known for a series of children's books that he wrote called The Chronicles of Narnia. And the lead book, the book that's most widely read, is The Lion, the Witch, and the Wardrobe. This is a very good book to read. It's a great book to read to your kids and your grandkids. And the Chronicles of Narnia take place in Narnia. Narnia is a magical make-believe kingdom. Human children, when they're approaching adolescence, at a time in their life where they're beginning to understand the difference between good and evil, right and wrong, and that their actions have consequences for themselves and others. When they're learning, how to be a good person, they can be whisked into the world of Narnia and live an entire life with the good people of Narnia and gain tremendous wisdom and insight. When they're old and gray in Narnian years, they can be whisked back to the human world, and they can retain all that they learned in Narnia, but only seconds have gone by in the human world. And what I think Lewis is trying to tell us is if you have the open mind of a child, if you're not burdened with preconceived notions, you can learn a great deal in a short period of time. And hopefully you all will learn a great deal in our time together tonight. So Narnia was a wonderful place. The rocks and the trees and the breeze and the brooks were all live and animate. They had souls. They lived in peace and harmony with the good people of Narnia. The sun was always shiny. The breeze was always cool. In Narnia, the doctors did not have to do a lot of paperwork, and there were no HMOs. But not all was well in the land of Narnia. There was a band of goblins and ghouls and evil elves, led by the vile White Witch, who wanted to kill the human children and enslave the good people of Narnia and make it winter forever, but never Christmas. And as Lewis tells the story, a pitched battle was fought on the plains of Narnia. Now, the good people of Narnia elected the human children to be their generals, to lead them into battle against the forces of evil. The human children knew they had a major challenge ahead of them because to defeat evil is very difficult. Evil is very powerful. Evil is seductive. It's quite easy to compromise and cut corners and do the wrong thing when it's expedient, especially if you're richly rewarded. It's difficult to always do the right thing, especially if someone tries to hurt you. It's easy to slip over to the dark side. So the human children knew they needed a special power to defeat the White Witch and her followers. They needed the deep magic of Narnia. To get the deep magic of Narnia, they had to go back in time to the origins of Narnia and understand why the witch was evil in the first place. Centuries earlier, she wasn't an evil witch. She was a beautiful, beneficial witch presiding over a wonderful Narnian kingdom. But over the years, there were problems when humans would not behave well. There would be a drought and the harvest would fail, and the food was distributed unequally. There were times of strife and intolerance and religious bigotry. And over the years, when viewing these episodes of when people were not acting at their best, the witch's spyglass of mankind became narrowed and corroded with layers and layers of hate and distrust. So at this point, all she could see was this narrow little opening, and all she could see was hate and evil. And that's what made the witch an evil witch. So the human children learned that. They did their work and understood why the witch was evil in the first place. With this understanding, they gained the deep magic of Narnia, took that back to the here and now of Narnia, used the deep magic to lead the good people of Narnia to defeat the White Witch and her followers in battle. But because they had taken the time and trouble to learn why the witch was evil in the first place and gained the deep magic, not only did they defeat the witch on the plain of battle, they were able to vanquish the witch and her followers from Narnia forever, so they could never return. Now, what was Lewis trying to tell us here? Well, he wrote these books in the late 40s and the early 50s, before my time, but not before many of you joined together with other good people of the world to defeat a great evil. But I think he's warning us, it's not good enough to defeat evil. You have to understand the conditions that allow evil to develop and prosper. If you don't deal with hunger and bigotry and intolerance and inequality and ethnocentric behavior, why, yes, you can defeat a Hitler and a Mussolini and a Hirohito, but if you don't deal with the causes that allow evil to spring up, you're going to have to fight the White Witch again in the form of a Saddam or an Andropov or a Gaddafi or that guy in North Korea. Now, what can we take from this now? We're talking about dealing with heart disease. We're battling heart disease. You come in with blocked arteries, I give you drugs, we do angioplasties, we do bypasses. We're trying to deal with that evil, but because we don't understand why those blockages are there in the first place, we have to fight that white witch in your arteries over and over and over again. So maybe what we'll do tonight is go back to the dawn of our time and ask and try to understand, why do we have atherosclerosis in the first place? Perhaps if we can understand why our arteries block up in the first place, why we have the genes for atherosclerosis, we can gain some deep magic of our own and bring it back and help you deal with your heart disease and vanquish it forever so it could never return. I'll start with a quote. This is from two-time Nobel laureate, smartest guy ever, Linus Pauling, and his student and disciple, Matthias Rath. Human atherosclerotic plaques are initiated by and primarily composed of lipoprotein A. The deposition of this substance between the cells of a vessel's wall directly parallels the extent of the atherosclerotic narrowing. The frequency of this pathomechanism today is directly related to its efficacy as a defense mechanism during the evolution of man, particularly in stabilizing the vascular wall during periods of vitamin C deficiency. The deposition of lipoprotein A in the form of largely intact particles implies the reversibility of this mechanism. That's a lot, but when I was in medical school, I was told by my professors that Linus Pauling was a doddering old man and that he was embarrassing himself talking about lipoprotein and vitamin C. And I was dumb enough to believe my professors, but I'm not that dumb anymore. And whenever someone who won the Nobel Prize twice speaks, we should listen. So let's go through his quote again, and I'll paraphrase. Human atherosclerotic plaques, that's cardiovascular disease, the blockages, are initiated by and primarily composed of lipoprotein A. This is the big culprit. The deposition of this substance between the cells of a vessel's wall directly parallels the extent of the atherosclerotic narrowing. The more plaque, the more lipoprotein A. The frequency of this pathomechanism today, that is, the frequency with which we have blocked up arteries, is directly related to its efficacy as a defense mechanism during the evolution of man. So it did something good for us at some point in the past, stabilizing the vascular wall during periods of vitamin C deficiency. He thinks atherosclerosis is a response to vitamin C deficiency. The deposition of lipoprotein A in the form of largely intact particles implies the reversibility. So if we can get rid of the lipoprotein A, perhaps we can get rid of the atherosclerosis. Here's a letter from Galileo to his good buddy Kepler. My dear Kepler, what do you say of the leading philosophers, here to whom I have offered 1,000 times of my own accord to show my studies, but who, with the lazy obstinacy of a serpent who has eaten his fill, have never consented to look at the planets or moon or telescope? Verify, just as serpents close their ears, so do men close their eyes to the light of truth. Galileo had proven, using mathematics and the new science of astronomy, that the earth revolved around the sun. Blasphemy. Everybody knew it was the other way around. The medical society, the Inquisition of the time made him recant, or they were going to kill him. So we have our problems with medical societies, but at least they don't want to kill us. Now, here's some comments from someone who's not fit to carry Pauling's slide rule or to utilize Galileo's abacus, but these are the thoughts of a physician who's open-minded and realizes how little he knows, which isn't a bad thing. So these will be Roberts's rules of biological order. Mother Nature's smarter than her children. She's particularly smarter than her children's physicians, who aren't nearly as smart as they think they are. I trained till I was 30 to learn how to do invasive procedures, but I didn't learn why my patients got sick, so I was not a very effective doctor. But we physicians aren't the only professionals or only segment of our society that's maybe a little arrogant. Think about the food processing industry, our agriculture system. We can get so many bushels of grain from an acre, the state of Nebraska could feed China. But now we've changed the grain, we've changed our food, we have a lot of it, it's no longer nutritious. all Americans are suffering from micronutritional deficiency because we've changed the food. We're not as smart as we thought. Everything in nature occurs for a purpose. Human health is no exception. All phenomena of human health occur for a purpose. There are no coincidences. Always keep an open mind. Now here's glucose. When you're in the hospital, we give you IV sugar water, that's glucose. If we say your blood sugar is high from diabetes, that's glucose. Everybody understands that glucose is really important. It's composed of 6 carbons and hydrogens and oxygen. And here's vitamin C. Now, most physicians would say, vitamin C is not important. If you take it, you just get expensive urine. You know, it's not very important for you. But it's funny, you know, glucose is so important, vitamin C is so unimportant, they look an awful lot alike, don't they? 6 carbons, they just differ in the distribution of the hydrogens and the oxygens. I guess that's just a coincidence. But remember, it can't be, because that would be a violation of Roberts' 5th rule of biological order. There are no coincidences in human health. We got to keep that in mind. And that brings us to our presentation tonight. I'll give you my major points. Vitamin C deficiency compromising the integrity of the vascular wall and allowing disruption of its surface is the most important underlying cause of atherosclerosis. Lipoprotein A, Mother Nature's artery patching response to vitamin C deficiency, is the initiating major propagating factor in human vascular disease. Lipoprotein A is the long sought after link between cholesterol deposition, that's atherosclerosis, and abnormal intravascular clotting, that's thrombosis, the 2 components of human cardiovascular disease. Lipoprotein A is truly the ugly cholesterol. Lipoprotein A is your enemy. To beat your enemy, you must first learn about it, try to understand it, then proceed forward with your new knowledge and overcome it and kick the white witch out of your arteries and never let her return. Recommendations. All Americans should take in at least 1,000 milligrams of vitamin C a day. 2 to 10,000 milligrams a day for those with active cardiovascular disease. Measure your lipoprotein A level. If elevated, lower the level and with it your coronary risk with vitamin C, niacin, testosterone in men, estradiol in women, and address your other risk factors. The use of the lipoprotein A binders, lysine and proline, can be considered, especially in those with extensive or rapidly progressive coronary disease who are not responding to conventional therapy, the people who see me. Keep an open mind as we continue to better understand the causes of atherosclerosis, and with that to develop new ways of preventing, stabilizing, or regressing human cardiovascular disease. Now I'm going to give you some facts. These aren't points that we would argue on. These are well-established facts. Man, the great apes, guinea pigs, and hedgehogs cannot manufacture vitamin C. All other animals have retained the ability to convert glucose into vitamin C. Man, the great apes, guinea pigs, and hedgehogs manufacture lipoprotein A. Lipoprotein A is not found elsewhere in the animal kingdom. Man, the great apes, guinea pigs, and hedgehogs all can develop atherosclerosis in nature. Vascular disease does not develop elsewhere in nature. They don't talk about it in veterinary textbooks. So we beings that make vitamin C cannot get cardiovascular disease in nature. We humans, the great apes, and our good friends, the guinea pigs and the hedgehogs, don't make vitamin C. We make lipoprotein A instead, and we can get cardiovascular disease. We and the great apes and the hedgehogs and the guinea pigs lost the ability to convert glucose into vitamin C about 40 years ago. A dog my height and weight would convert glucose into vitamin C in its liver and make about 20 grams a day, 20,000 milligrams, twice that much when stressed. But we lost the ability to make vitamin C from glucose about 40 million years ago. Mother Nature can change your blueprint. I want to talk a little bit about genetic mutation. And I don't want to offend anybody, because I offend people all the time. I don't want to offend you. Some of you believe in creation, that a deity put us on the earth much as we look now. Some of you believe in evolution, that there was this sea of carbon and hydrogen and nitrogen that got hit by a bolt of lightning and the first unicellular organism developed into mankind. Or some of you believe in this divine, intelligent design, that a divine being helped evolution. Whatever philosophy you believe in, we do know that the gene pool can change, and this is a process of mutation. And this is Darwin's theory, so to speak. So mutations do occur. They can be beneficial, dead end, or good at one point and bad at another. I'll give you some examples. Consider some birds, a flock of birds living on a desert island. The only food are bugs that are under rocks. When the weather's good, there's plenty of bugs, the birds are all fat and happy. Then there's a drought. The bug supply dies off, the birds begin to starve, they can't get at those bugs. And one day, a baby bird is born with a genetic mutation to have a long beak. Now that bird is going to have an advantage over all the other birds. It can get deeper under the stones and get the last few bugs. So the bird with the long beak, the abnormal bird, won't die. Most of the other birds will die off. Well, then the weather's a little bit better. But now you have in the bird population a small knot of birds with long beaks. 25 years later, there's another drought. All the short-beaked birds begin to die. The long-beaked birds make it through. You know, after a few hundred years of this and a few droughts, all the birds will have long beaks because that had survival advantage. We will mutate, we will change to fit into a changing environment. There can be dead end or terminal, like being born without a vital organ. It's a disaster for you or your family, but you're not going to pass on those genes to your offspring. And then there can be good and bad mutations, preventing devastating disease and an extinction of society at one point and causing disease in another. So let's talk about sickle cell anemia. I trained at the University of Cincinnati, had a big sickle cell population. We get one gene for our hemoglobin from our moms, one from our dads. Sickle cell is a genetic disease where your hemoglobin will be abnormal. And if you have two bad genes, when you are stressed, infection, or any sort of illness, these red cells, the sickle cells, will crinkle and stick, and they'll get stuck in your capillaries and kill the cells served by that capillary. You can have heart attacks, liver damage, brain damage, bone infarcts. It is a miserable disease. You're constantly in and out of the hospital, you require morphine for pain, and it's just a miserable thing. And most of the people afflicted with sickle cell die before they turn 30, but they have a miserable life. We only see sickle cell in American blacks. And when I was treating these people, and they're nice looking people, but they have no life to live, I was asking, why would God or evolution put this curse on the black population to have sickle cell? We don't have it in whites. Well, it turned out, remember, everything in human nature occurs for a purpose. Turns out if you have sickle cell, you can't die of malaria. The malaria parasite is passed to humans via mosquito bite. And it will enter your bloodstream, enter your red cells, and kill you. And in rural Africa, thousands of millions of years ago, the malaria parasite would wipe out entire populations. One day, a baby was born with a genetic defect to have sickle cell. And if you have sickle cell, you're resistant to the malaria parasite. So that kid did not die, and everybody else died, and that kid could pass on his sickle genes. Now, sickle cell is not a good thing to have, but you live to adulthood and to pass on the genes. Now, if you have only one bad gene, you live a pretty normal life. You're a carrier, but you have a pretty normal life. Two bad genes, you make it to 25 and die, but you can pass on the genes. So that we have a small knot of people in the community that have sickle cell, or the trait, and then there's another wave of malaria. They all survive, everyone else dies. So now we see in African blacks, there's a high frequency of sickle cell in the population because it allowed you to survive malaria. And American blacks are descendants of African blacks, and they carry the gene as well. Now, we've drained our swamps. We don't have malaria. So what was a beneficial mutation at one point now causes a nasty disease today. But that's the purpose of sickle cell. Could you think of other diseases that we look upon, genetic diseases, as a curse today that might have been beneficial at some other point in our development, at some other point in time, such as cardiovascular disease? We're going to talk about atherosclerosis, thrombosis, coronary disease, cholesterol, lipoproteins, apolipoproteins, HDL, LDL, plasminogen, plasmin, ascorbic acid, endothelial dysfunction, and hormone replacement therapy. Cholesterol. You know, when we say your cholesterol's high, we're referring to blood cholesterol and the transport proteins called apolipoproteins that allow it to travel in the circulation. Your blood cholesterol is actually an amalgam of LDL, HDL, and VLDL. VLDL is not quantitatively important, so it's the LDL and HDL. LDL is low density. This is the one that'll plug up your arteries. L for lousy. HDL is an antioxidant that carries out reverse cholesterol transport. H for happy. You want a high HDL and a low LDL. Now, lipoproteins. Cholesterol itself is a blob of fat. It is insoluble in blood. So Mother Nature will encase the cholesterol globule in a specific protein called an apolipoprotein to form a blood and water-soluble lipoprotein which can transport cholesterol within the circulation. LDL contains 2,000 molecules of cholesterol and the apolipoprotein B particle. HDL contains cholesterol associated with apolipoprotein A. So they're good or bad, not due to the cholesterol, which is the same, but to the apolipoproteins. So you have the fatty globule, you'll surround it with the apolipoprotein to form a blood-soluble lipoprotein. Lipoprotein A is one bad LDL attached to apolipoprotein little a, which is like a Velcro strip. So lipoprotein A is a very sticky LDL. Plasminogen, ogen means to bring forth. Plasminogen is an inactive precursor enzyme. When it is exposed to TPA, tissue plasminogen activator, it's converted to plasmin that dissolves a clot. When our arteries are nicked or cracked, we want to form a clot there. But we don't want the clotting to be overexuberant and close off the vessel. So we immediately kick in our clot dissolving system to trim the clot. When a vessel is traumatized, it'll release TPA, tissue plasminogen activator, to activate plasmin right then and there. So you will dissolve that clot right then and there, as opposed to throughout your body. Now, if you come into the hospital with a heart attack, a coronary thrombosis, we will give you IV TPA to dissolve the clot. Bacteria can be taught to make TPA. It's now a drug, and it'll dissolve clots throughout your body. This is a good advance in medicine based upon an understanding of Mother Nature. Well, what are the properties of plasminogen and plasmin? They dissolve blood clots. How do they know where to go? Well, if the vessel is cracked, the collagen, that's this tough fibrous protein that provides elasticity and resilience to the vascular wall, will be cracked. And it's composed of amino acids lysine and proline. So lysine and proline will be exposed to the circulation. And plasmin recognizes lysine and proline and binds to it. So it knows where to go. It goes to the site of vessel injury where the clot is forming by binding lysine and proline. Plasminogen inhibits the growth and migration of smooth muscle cells within the vascular wall. It does not enhance the stability of the vascular wall. It does not promote wound healing. All it does is dissolve clots, and we've been able to make plasminogen and dissolve clots for over 40 million years. Apolipoprotein A is an adhesive protein, combines with LDL to form circulating lipoprotein A. It antagonizes plasmin. It prevents plasmin from dissolving clots. Just as plasmin binds to expose lysine and proline in the vascular wall, so does apolipoprotein and lipoprotein A. They compete with one another. By binding the lysine and proline sites, it'll prevent plasmin from attaching and dissolving blood clots at the site of the vessel wall, and it carries LDL cholesterol with it to where it is needed at the site of vascular wall injury. It does promote the growth and migration of smooth muscle cells within the vascular wall, does enhance the stability of the vascular wall, does promote wound healing, looks a lot like plasminogen. It's a plasminogen imposter or mimic, sharing multiple amino acid sequences. It lies next to plasminogen on chromosome 9 and arose as a mutation of plasminogen 40 million years ago. If my trunk is a damaged blood vessel wall, my right arm is plasminogen plasma, my left arm is the lipoprotein A. The shoulder segments are identical, and they will bind to lysine and proline. Where the genetic mutation was would be in my arms and hands. Plasminogen dissolves clots, The apolipoprotein A forms clots. If, then there's only so many lysine and proline binding sites. You got a lot of plasminogen and plasmin, you dissolve clots well. You got a lot of apolipoprotein A and LPA, you don't dissolve clots well. And as we'll show you, the apolipoprotein A arose as a mutation from plasminogen about 40 million years ago. Vitamin C is our primary circulating antioxidant, participates in multiple physiologic processes. It converts lysine and proline to hydroxylysine and proline, promoting and strengthening collagen. It does enhance the stability of the vascular wall, does promote wound healing. We lost the ability to make vitamin C about 60 million years ago. Compare and contrast. Plasminogen prevents clotting. It doesn't strengthen the vascular wall. It doesn't have an antioxidant effect. ApoA and the lipoprotein A promotes clotting. It does strengthen the vascular wall. It has a slight antioxidant effect. Vitamin C, which we can't make anymore, does not affect clotting. It does strengthen the vascular wall, antioxidant effect. As we're going to see, we wound up making apolipoprotein A and lipoprotein A to compensate for the loss of vitamin C 60 million years ago. Now, wouldn't it be neat if your coronary disease presented in a slow, progressive, methodical fashion? I could do your heart cath now, again in 2 years, and say, Mrs. Smith, by my calculations, you will have a 90% narrowing in 3.7 years. So in 3.5 years, let's do another heart cath and do your angioplasty. Wouldn't that be nice? But it doesn't work that way. Coronary disease progresses unpredictably and often rapidly in a series of leaps and bounds, fits and starts, with periods of atherosclerosis alternating with periods of thrombosis, clot formation. According to the Pauling and Raft theory, the initial lesion, initial abnormality, is a break in the vascular surface due to not enough vitamin C to give you good collagen. Atherosclerosis forms over the break. It is a healing repair process. A crack will form within the plaque, and a thrombus, a clot, heals over that crack. This clot is healed over with more atherosclerosis. Over time, another crack, another clot, more atherosclerotic healing. Finally, there's a terminal event. One plaque rupture too many, you close off and have a heart attack or a stroke. Look to the cause points to the cure. A better understanding of the cause of the components of coronary disease, atherosclerosis and thrombosis, leads to better solutions. So I'll give you a timeline of my personal understanding of atherosclerosis and thrombosis. When I was in medical school, the teaching was cardiovascular disease, atherosclerosis was due to high cholesterol, so we said lower your cholesterol. Then we learned, well, the LDL's the bad guy, the HDL's the good guy, so lower your LDL, raise HDL. About 15 years ago, we learned that LDL must be oxidized before it can harm us, so we said, take antioxidant vitamins. And then Linus Pauling is telling us that lipoprotein A, not LDL, initiates atherosclerosis, promotes the growth of the plaque. LDL follows along in his theory. So lower your LPA and neutralize as well as LDL. Vitamin C deficiency weakens the vascular wall, allowing the first surface disruption to occur, allowing lipoprotein to attach and initiate the atherosclerotic process, so supplement your vitamin C status back to that of a healthy animal. Let's look at blood clotting. When I was in medical school, we learned that coronary disease was due only to atherosclerosis, plaque formation, no role for anticoagulants. When I was an intern, the teaching changed. We thought that coronary disease was due to atherosclerosis, but a fibrin clot, like a scab, closes the artery to produce the heart attack. So we'd put you on blood thinners after the heart attack, which is kind of like closing the barn door after the horse left. But then when TPA came out to actually dissolve the clot, we began to treat heart attacks with TPA to make plasminogen and dissolve the clot, and that really revolutionized cardiovascular medicine. We now know that coronary disease produces in fits and starts with small platelet fibrin clots that heal by atherosclerosis. Prostaglandins play a role in platelet stickiness. We talked about that last week. So we'd say take aspirin to wipe out all the prostaglandins. But we know that some prostaglandins are good, some are bad, and now we're going to say it's an imbalance in prostaglandins, so we're going to supplement you with fish oils and gamma-linolenic acid. And we're going to, Pauling and Rath feel that lipoprotein A promotes fibrin blood clot formation, so lower your lipoprotein A. Lipoprotein A causes plaque and clotting. It's the long sought after link linking the two major causes of cardiovascular disease, plaque deposition and clotting. It's lipoprotein A. Now, I said we'd go back in time, so let's go back to Cartier's scorbutic expedition to Canada. Jacques Cartier of France discovered Canada in 1753, but his timing was bad. He and his crew were stuck in the St. Lawrence. They were icebound. And on these cruises back then, they didn't have a lot of good stuff to eat. They lived on a diet of crackers and salt pork, and the officers would get a tot of rum every night. And the crew, you know, they were icebound. They couldn't go out and hunt and get any fresh foods. And the crew began to fall ill, bleeding from their mouth and mucous membranes, loose joints, unexplained bone fractures. The Indians, and the ship's cat didn't get better. Wasn't that odd? The Indians gave them a tea made of pine needles and applied a poultice of pine bark. They all got better. What happened here? What was the disease state? Scurvy. And why did they get scurvy? No vitamin C in their diet. Why didn't the cat get sick? Cats make vitamin C. And in the tea and the poultice was vitamin C and bioflavonoids. Let's go back further to the near extinction of man during the Ice Age. Atherosclerosis to the rescue. Primitive man didn't make vitamin C or ApoA. He did make plasminogen. Vitamin C was plentiful in the diet, lots of fruits and vegetables. Vessel wall integrity was preserved, lots of collagen, no disruptions, no cracks in the vessel wall. Well, then the Ice Age hit. Agriculture ground to a halt. Mankind didn't get fruits and vegetables, became vitamin C deficient. Cracks began to develop in the vasculature, and mankind began to bleed and die of iron deficiency anemia from these leaky blood vessels. Now, the plasminogen did a good job of preventing blood clotting. Well, so mankind was going to die. You know, everybody was going to die off of this. And then one day a child was born with a mutation of plasminogen to make ApoA, which prevented plasminogen from dissolving blood clots, slowing down the bleeding. Now, the ApoA binds to LDL cholesterol and brings it in to this wound. By bringing LDL cholesterol to the site of vessel damage and by promoting vascular smooth muscle growth, ApoA improved vascular integrity, temporarily patching the artery. Now, there would be breaks in the Ice Age, and there'd be times when vitamin C was available in the diet and the artery would heal up. Vascular integrity was stored. The ApoA atherosclerotic patch returned to the circulation. The genes of atherosclerosis were given to us by Mother Nature to help plug up the dike during periods of vitamin C deficiency. Then when we get some vitamin C, we heal up again and the plaque resorbs. But today, we're chronically vitamin C deficient. ApoA is constantly called upon to patch up cracks in the vessels. LDL continues to be pulled into the vessel wall by ApoA, now narrowing the vessel. That's atherosclerotic plaque. ApoA promotes blood clot formation, thrombosis, producing coronary disease, and eventually a heart attack. In this theory, vitamin C deficiency, chronic vitamin C deficiency, which is present in Western societies, is the culprit. How do you want to stabilize your arteries? Take plenty of vitamin C, have good strong collagen so your vessels don't crack and you don't need to repair them, or don't take a lot of vitamin C and let your risk factors repair your arteries and then come into me for a heart cath and a stent and a bypass and an ECP and an MME and then maybe a heart transplant. The decision is yours. Lipoprotein A is associated with endothelial dysfunction, which we'll talk about in a few weeks. It's the most potent risk factor for cardiovascular disease, milligram for milligram with 10 times the plaque-producing power of LDL. It concentrates in the plaques in native arteries and bypasses. It's deposited in intact form, implying reversibility. It's under genetic control. It has to do with how well your ancestors were equipped to deal with vitamin C deficiency. Diet has a minimal influence except that trans fats make it go up. Levels range from 0 to 100 in humans with an average value of 14. The 90th percentile is 35, the 95th is 14. The average level in patients is 19 versus 13 in healthy people. In my practice, I've had people up to 250 because I deal with people who are not doing well. They're not doing well from their high LPA, so they come in and see me. LPA is associated with the presence of cardiovascular disease, extent and severity of the blockages, risk for unstable angina and heart attack, poor outcome following unstable angina or heart attack, poor outcome after angioplasty or bypass, impaired angiogenesis. An LPA above 30 doubles your risk. If your LDL is also high, your risk increases by a factor of 5. A low HDL in the presence of other risk factors also magnifies the risk associated with a high LPA. 90% of people whose bypass grafts clog have LPA levels above 31. Patients with re-narrowing following balloon angioplasty have an average level of 19 versus those whose arteries stay open who have a level of 7. LPA is a repair particle. Angioplasty is trauma. So Mother Nature wants to come in and repair it, does too good a job, and we re-narrow. We have restenosis. Patients with a level, an LPA above 40, are 11 times as likely to re-narrow as those with a level below 4. Those with a level above 19 are 6 times as likely to re-narrow. Lipoprotein A increases your risk of clot formation in atrial fib. You want a low LPA. LPA is not the way to keep your vessel wall intact. A better approach, maintain vascular integrity with vitamin C. Don't rely on the atherosclerotic patch system to deal with rents in the vessel. Optimize vitamin C level, maintain vascular wall integrity. It'll hydroxylate the lysine and proline, hiding them from the lipoprotein A. Lower your other risk factors, so measure your LPA, lower it with vitamin C and other means, neutralize it with supplemental lysine and proline, remove LPA from plaques with optimal doses of lysine and proline. This could produce disease regression. Vitamin C stabilizes the vessel wall. It makes stronger collagen. Collagen strengthens the vessel wall. With a strong vessel wall, wear and tear injury does not occur. Without vessel injury, the LPA patch is not deposited, atherosclerosis is not initiated, no abnormal surface upon which clotting can occur, coronary disease won't happen. It doesn't happen in animals that make vitamin C, only in animals that don't make vitamin C. Lysine and proline. LPA must bind to lysine and proline on the surface of a damaged vessel before it can bind in and initiate plaque deposition and clotting. If we flood your circulation with supplemental lysine and proline, all the lysine and proline binding sites on the circulating LPA particle will be occupied. So LPA will bounce off the vessel wall because it can't bind to lysine and proline in the vessel wall. And so the LPA will be neutralized. It can't hurt you. If we give you a lot of lysine and proline particles can insinuate themselves between the lipoprotein A and the vascular wall and pull off the lipoprotein A, in theory producing a reversal of cardiovascular disease. So let's talk a bit about lipoprotein A. Endothelial function is the most important predictor of your outcome. If your endothelium is intact, you'll do well. If it's shot, you're doomed. We're going to take 108 patients undergoing angiography for stable angina. The majority had obstructive cardiovascular disease. They had risk factors. Now, but some had normal arteries. They had chest pain due to maybe esophagitis. Individuals with plaque had a lipoprotein A level of 26 versus the normal artery group 14. Their cutoff was 30 for a high LPA, and that was present in 31 of the patients. 77% had lower values. So this was the cutoff point for a high versus low. Now, we're going to measure endothelial function. We'll talk about this later, but in response to an injection of acetylcholine into the coronary artery, it should dilate. Cold pressor testing, we immerse your hands in ice water and your blood vessels should dilate, but if your endothelium is not working well, they'll constrict. And we're going to correlate endothelial function with LPA levels. Now, with acetylcholine, the people with high lipoprotein constricted 15%. Those with normal lipoprotein did not constrict as much. In response to the cold pressor test, those with high lipoprotein constricted a lot. Those with low lipoprotein did not. So lipoprotein A is associated with endothelial dysfunction. Anything that causes endothelial dysfunction is a major predictor of a bad outcome. What are LPA levels in coronary patients? Here we're going to measure lipid levels in 306 patients undergoing bypass, 72 age-matched controls. Now the coronary patients, they had higher LDLs and they had lower HDLs, but their lipoprotein was 25 versus 14 in the healthy people. In the bypass patients, 40% had an abnormally high lipoprotein A versus 16% of the control. So people with cardiovascular disease have higher lipoprotein A's than people with lower ones. In the blood, that is. What about the level of LPA in the atherosclerotic plaque? Here we're going to take 107 patients undergoing bypass, measure their blood lipid levels, and then biopsy the plaque and look at the lipid content in the aortic wall. Now for the entire group, the LPA was 22, 14 had lower values, 33 had higher values. Those with higher lipoprotein A's had a little more cholesterol in the vascular wall, a little bit more protein. They had a lot more triglycerides. The amount of free LDL in the vascular wall was the same, whether your lipoprotein A was high or low, but LDL bound to lipoprotein A was higher in those with a high lipoprotein A. The idea is the lipoprotein A carries LDL into the vascular wall. The LDL is following along in the Pauling raft theory. Now, there was no correlation between the LDL level in your blood and in your vascular wall, as you would think, right? But there was a strong correlation between the level of LPA in your blood and in your vascular wall, suggesting it's the primary culprit. The LPA is found in the inner layer of the enema. High LPA correlated with LDL deposition in the aortic wall. The thinking is LPA is dragging the LDL in. Here, again, we'll look at LPA within coronary plaque. 11 patients studied at autopsy, measure lipid deposition patterns within the wall of the aorta and one of the coronary arteries, left anterior descending. Here we have people with low-level plaque. Here we have people with plaque involving greater than 50% of the vessel. And the more severe the plaquing, the greater is your cholesterol, the greater is your triglycerides within the vascular wall. The LDL is a little bit higher, but so is the LPA. They found that LDL and LPA co-localize within the inner lining. LPA was extracellular and easily extractable, suggesting that you could come up with strategies to pull it out of the vessel wall in living humans. Let's look at the relation between LPA and disease extent and severity. 202 patients are undergoing a heart catheterization, and they, 37% had stable angina, 30% had a remote heart attack, none on lipid-lowering drugs, none with a recent heart attack, none on estrogen therapy, which will lower your LPA. We're going to correlate lipid levels with the extent of coronary disease, how many vessels are involved, the prevalence of vessel occlusion, and the prevalence of unstable angina or prior heart attack, complications of cardiovascular disease due to plaque, rupture, or clotting. Now, here we're going to look to see if there's a correlation between variations in your lipid levels and the number of arteries blocked. Now, for the group, the average cholesterol was 234, and if cholesterol was the big culprit, we would expect to see a stepwise increase in the cholesterol as a function of do you have 1, 2, or 3 vessels blocked. And there was not a strong correlation. There was no relationship between your triglycerides and how many vessels were blocked. LDL was higher in those with 3 vessel disease. Now, HDL was fairly predictive. There was a prediction there in that the higher your LDL, the less likely you are to have multivessel coronary disease. Those with normal vessels, it was 47. Those with 3 vessel disease, it was 40. But the stepwise gradation that you expected to see was in the lipoprotein A. It was 12 in people with clear arteries, 18 with 1 vessel, 26. So as your lipoprotein A rises, so does your risk for the extent of your cardiovascular disease. What about complications of cardiovascular disease? Heart attack and unstable angina. Here, in people who had never had a heart attack, the LPA was 17. Those with a prior heart attack, it's 25. Unstable angina, if you've never had unstable angina, it's 17. If you had, it was 22. People who never had unstable angina, never had a heart attack, it was 15. People with both heart attack and unstable angina, it's higher. Intermediate if you had only 1. So lipoprotein A correlates with the extent of your coronary disease and your risk of a complication due to plaque rupture or clotting. Here we're going to look at the relation between lipids and the number of occluded vessels. The greatest predictor was the lipoprotein A, far more than the LDL or the HDL. So your lipoprotein A level is associated with more extensive coronary disease, more occluded vessels, unstable angina, prior heart attack, or both. LPA and heart attack risk. We're going to look at LPA levels in 303 men with a prior heart attack, 408 age-matched controls. Now, overall, the LPA level was 17 in the heart attack victims, about 14 in the controls. But if we look at young people, people with heart attacks below age 60, there's a much bigger differential. It's 17 versus 12. If you're older than 70 and you have a heart attack, the difference is not as much. Now, lipoprotein A is the big cause of heart attack in young people. When we have a young person with a heart attack, they always have a high LPA. If you're 70 or 80 and you have your heart attack, the LPA is not as big a factor because after 7 or 8 decades, the blood pressure, the sugar, and the cholesterol gets to you. But the point here is LPA is often the explanation of premature cardiovascular events. Here they divide them into quartiles, increasing 25% brackets. The relative risk of a heart attack if you were in the 4th quartile versus those in the lower 75% of the LPA levels. Overall, you're 1.7 times as likely, but if we're looking at youngsters, those less than 60, you can see your risk is 2.5-fold increased. So it's a bigger problem in young people. LPA in post-heart attack, post-myocardial infarction, vessel patency. A heart attack occurs when a clot, a thrombus scab, forms in your artery. The clot can be dissolved by thrombolytic drug therapy, the drugs we give you, the TPA, or your body can dissolve it. Your plasmin can dissolve it. Now, we want that clot to be dissolved because if you have a heart attack and the clot is dissolved and you have an open artery, that's associated with salvage of heart muscle, less left ventricular enlargement, better maintained pumping function, reduced risk of arrhythmia, improved long-term survival. So we'd like to keep those arteries open. We'd like to be able to dissolve those clots after a heart attack, either by drugs or have your own body do it. Will LPA have an effect on that? 105 coronary patients. Now, at this point, they're 2 years out from an initial heart attack. None had received clot-busting therapy when they had their heart attack. You do an angiogram 1 to 3 weeks following the heart attack. The vessel was open in 52, their ejection fraction 61%. The vessel remained closed in 53, their ejection fraction's lower at 55%. The ejection fraction is the percentage of blood your heart expels with each beat. You want a high ejection fraction. The worse the heart attack, the more muscles damage, the lower the heart attack. So if the artery was open, you have better preserved pump function, a higher ejection fraction. Now you're going to draw blood work 2 years post-heart attack and stratify by open or closed artery 2 years earlier. And there's really no difference in cholesterol, triglycerides, HDL, LDL. Fibrinogen, the precursor of clot, was a little higher in those with closed artery, but the big differential was LPA. 49 in those who could not dissolve their clots, 19. So if you have a heart attack and you got a high LPA, you're not going to be able to dissolve that clot because the LPA prevents the plasminogen and plasmin from doing what Mother Nature intended. So therefore, you would predict that it would increase your risks following a heart attack. Here we're going to take 462 patients with an acute coronary syndrome, 266 with heart attack, 197 with unstable angina. All received standard medical therapy. Now their LPA level was measured and their physicians were not informed of the value. And you're going to follow their course over 3 years and see if their baseline LPA level had anything predictive value for their outcome. And we're going to look at the people that had heart attacks. The average level's 13. 25% were above 30. They were abnormal. 3-year post-heart attack mortality was 19% in those in the lower 75% of lipoprotein A's. Those with a high level above 30, it was 30%. If you look at mortality rates, you can see it's much higher in the high LPA people than in the low LPA people. The difference begins at about 200 days. Why? Because they're more likely to clot up again. If you look at patients with unstable angina, those with levels above 30 had a 24% 3-year mortality versus 13% of those below 30. Here in red are the high LPAs, in blue are the low LPAs, in green is the intermediate. So it's kind of a continuous risk. So if you have a heart attack or unstable angina, you got a high LPA, you're more likely to get into trouble. LPA and restenosis. 240 consecutive patients with successful balloon angioplasty record baseline lipid and LPA levels, reevaluate 6 months out from the LPA. Now 40% re-narrowed, 60% did not re-narrow. Now, what happened, can we predict this from your lipids? Well, there was no real difference in the LDL or the HDL, cholesterol, triglycerides, in the re-narrowers versus the non-re-narrowers. No difference in lipid drugs, but the LPA was 20 in those who maintained their gain. It was 34 in those who re-narrowed, because LPA is a repair particle, it overdoes it and plugs up the angioplasty site. If you divide them into quintiles, the restenosis rate was 60% in those in the upper 20%, above 43, and it was only 27% in those with levels below 6. Your odds of restenosis versus the lowest quintile, if you're in the upper quintile, the upper 20%, you're 4 times as likely to re-narrow as somebody with a lower lipoprotein A. So if you have a balloon angioplasty, your LPA is high, your odds of re-narrowing are greatly increased. Well, if that doesn't work, we can do an open heart. But then we got to keep the grafts open. Will LPA clog up our bypass grafts? 198 subjects undergoing angiography to deal with chest discomfort. 32 had normal vessels. They might have had gastroesophageal reflux. Then we got 167 patients that were symptomatic following bypass. You're going to carry out quantitative vein graft, saphenous vein graft angiography, measure LPA levels, correlate status of the vein grafts with the patient's LPA level. Now, individuals, we're going to look at the people that had bypass surgery and have recurrent pain and have a bypass. Those where the grafts look good, they're 19%, and 81% had graft disease. And at least one graft was narrowed in 70% of those that had only one graft placed, 86% of those that had 2 grafts placed, 83% of those that had 3 grafts placed. Now, we're going to see if we can predict open grafts versus closed grafts. Age didn't make any difference. Time interval did. Those who narrowed a graft were 7 years out from bypass as opposed to 5.2 years out. That makes sense. The longer the vessels are exposed to risk factors, the more likely you are to close off. No real difference in smoking, obesity, blood pressure, cholesterol, diabetes really, but LPA was a big differential. In the normal people that had gastroesophageal reflux, normal arteries, they're level 17. Those who held on to their grafts, they're level 17. Those who closed their grafts, it's 32. Same situation with bypass grafts and balloon angioplasty. It's a repair particle, it overdoes it and closes you off. And the relationship was present in women and in men, and it was particularly high in young men who closed off their grafts. So this is the big predictor, the big culprit in young people. And for every 1 milligram change in your LPA, your risk of graft disease rose by about 2%. Lipoprotein A and atrial embolism. If you have atrial fib, which is a very, very common arrhythmia, maybe 5%, 10% of seniors have it. The atria are beating like a sack of worms, not priming the pump, the ventricle, and that can lower your cardiac output. But the real worry is when the atria are beating like a sack of worms, a clot can form, and it can be ejected and cause a heart attack or a stroke or kidney failure and ruin your life. So we're going to put you on blood thinners to prevent that from happening. But blood thinners have a downside too. So this is a tough risk to benefit decision that I make almost every day. Do I not put you on blood thinners? The more I know about your risk of forming a clot, the better decision I'm going to make. Now, we're going to take 172 patients with atrial fib, none on Coumadin anticoagulation, 34 had embolism or a known clot on their transesophageal echo, 138 did not have a clot. Those that had clots had an LPA level of 32, those without a clot, 16. If your relative risk of having a clot, if you were in the first quintile for LPA, was 9%. If you're in the upper 20%, it's 59%. If your LPA is above 30, you're 9 times as likely to clot as opposed to people who have lower levels. So if I'm on the fence as to whether to give you a blood thinner or not, I'm going to look at your LPA. If it's high, I know you're at great risk of forming a clot in your atria, so I'm going to give you blood thinners. If your LPA is low, your risk is less, I may not give you blood thinners. It clogs up vessels and promotes clots. What are we going to do about this? We're going to give you vitamin C. Take 11 coronary patients, treat them with 9,000 milligrams of vitamin C a day, kind of like animal levels, over 2 weeks, and we see the lipoprotein A falls by 27%. Niacin, 31 consecutive lipid clinic patients, all on a standard diet, none with high triglycerides, give them niacin, 1,000 milligrams 4 times a day, and we see cholesterol drops 10%, triglycerides 24%, LDL 13%, HDL rises by 46%, LPA falls by 38%. Other drugs will not lower your lipoprotein A. Niacin will. Fish oil and lipids. You saw this slide last week. If we treat you with 12 grams a day of fish oil versus rapeseed oil, we can see that both groups, your weight will fall. Rapeseed oil does a little bit better with LDL than fish oil, but fish oil will lower your lipoprotein A 14%, whereas rapeseed oil has no effect. So fish oils are also useful in lowering your lipoprotein A, and of course avoid trans fats because they drive it up. So drop the trans fats, take the fish oil, your LPA will fall. Carnitine, which we'll talk about next week, it helps us make ATP. Carnitine also has a favorable effect on LPA. 94 subjects with newly diagnosed type 2 diabetes and high LPAs record a baseline LPA, randomized to receive over 1 year. Carnitine, 1,000 milligrams twice a day or placebo, reevaluate, and you see that with control there's no real effect. LPA fell by 20% with carnitine, certainly a plus. Testosterone and lipoprotein A. The major hormones will affect LPA. If you're hypothyroid, it goes up. If you're hyperthyroid, it goes down. Estradiol will lower LPA in women. IV growth hormone makes it go up. Here we're going to take 19 healthy men, measure their lipid values over a 4-month baseline, then give them a huge dose of testosterone. 200 milligrams intramuscularly every week over 20 weeks. Here they were using it as a male contraceptive, thus the high dose in young people. And then 4 months you reevaluate. And they found there was no relationship between the baseline testosterone and LPA values, no permanent effect of short-term testosterone therapy on lipids or LPA. The lipids didn't change a whole lot on testosterone, except the LPA fell from 24 to 19. But if you looked at individuals that had high baseline LPAs above 25, the value fell from 43 to 27. So testosterone in men is helpful with lipoprotein A. Now we've been talking about testosterone in men, therefore it is fair to talk about estradiol in women. The PEPI study. Now you've been hearing about how horrible estrogen is. 5 years ago, all women had to take estrogen or they were bad women. They were bad patients if you did not take your hormones. Now, of course, it's just the opposite. You're a bad woman if you take estrogen. See, we go back and forth, back and forth. But let's actually talk about the science, not the media hype. The PEPI study, postmenopausal estrogen progesterone intervention study. We're going to look at 875 middle-aged women who did not have known cardiovascular disease. Randomized to receive over 3 years Premarin, which is horse urine extract, so you're getting horse hormones removed from their urine. That's what Premarin is, pregnant mare urine. The other group got Premarin and Provera. This isn't progesterone, the hormone that your ovaries make. It is a man-made chemical and kind of like a trans fat, sort of. Another group got Premarin and cyclic Provera. Another group got Premarin and progesterone or placebo. We're going to measure the lipoprotein A levels periodically. And what you see here is that all of the Premarin groups, the lipoprotein A levels fell. With Premarin alone, the LPA falls by 26% at 12 months. It's down by 20% at 36 months. And all of these combinations worked. So Premarin or estradiol or any estrogen replacement therapy is going to lower your lipoprotein A. Well, what will that do for you? Let's look at hormone replacement therapy, risk reduction, and LPA. This is the HERS study, heart and estrogen progesterone replacement study. Just below 3,000 postmenopausal women, and they had known cardiovascular disease. Randomized to receive Premarin and Provera, two, horse-made and a man-made chemical, not the real stuff that your ovaries made, or placebo. periodically measure LPA, and follow them for cardiovascular events over 4 years. Double-blind protocol, so there's no bias. Now, let's look at the 4-year relative risk of a cardiac event in relation to your baseline LPA. Here we're going to divide the LPA values into quartiles, the lowest and the highest. The women in the highest quartile for lipoprotein at baseline were 50% more likely to have an adverse event, 50% more likely to have a heart attack, 40% more likely to die. Those in the third quintile were twice as likely to die. They were more likely to have unstable angina or require revascularization. Well, what's the effect of Prempro on your lipoprotein A? It's a function of your baseline lipoprotein A. In blue is placebo, it had very little effect. Red is Prempro. Individuals in the lowest quartile, there wasn't much effect because their LPA is only up to 7. As your baseline LPA rises, you see a greater effect of the Prempro on lowering your lipoprotein A. Those in the highest quartile dropped by 12%. So the higher your LPA, the greater it's going to fall with Prempro or any other hormone replacement therapy. If your LPA is normal or low, nothing's going to happen. 4-year relative risk for a cardiac event, Prempro versus placebo as a function of your baseline lipoprotein A level. Now, if you have a low lipoprotein A and you get Prempro, your risk rises by 40%. But if you have a high lipoprotein A, your risk falls by 15%. You're less likely to die if you had a high LPA than a low, much less likely to have an event than if you had a low. Risk reduction due to Prempro is related to the degree of decrease in the LPA due to Prempro. In the upper quartile of baseline LPA, it falls by about 9 points. 38% risk reduction versus the lower quartiles. Change in risk for heart attack or death with Prempro HRT over time. Remember, this was the study that said you should not take HRT. Over 5 years, it had no benefit. Well, and that's true, but if you, here we're going to look at the effect of HRT on outcome as a function of whether you had a high or a low LPA at baseline. If we look at all subjects, in the first year, there was a 60% increase in events. Over years 2 through 5, there was a 20% protection. So over 5 years, there was no net effect. If you look at women with low lipoprotein A's who were put on Prempro, because again, their lipoprotein A's are low, it can't fall further. In the first year, by taking Prempro, you double your event rate. In years 2 through 5, you increase it by 10%. Bad idea. But if you had a high LPA, women, postmenopausal women with coronary disease and a high LPA, during the first year, your risk rises by 26%, and over years 2 through 5, it falls by 32%. The net effect is beneficial. LPA is an independent risk factor for coronary events in postmenopausal women. Prempro lowers LPA. LPA reduction is associated with a decreased risk. If your baseline LPA modifies the effects of Prempro HRT. If your LPA is high, you have a short-term mild risk, long-term benefit, you ought to do it. If your LPA is low, short-term major risk, no-term long benefit, you shouldn't do it. So when I'm thinking about hormone replacement therapy in a postmenopausal woman with cardiovascular disease, how do I make my decision? I look at your LPA. If it's high, I will treat you. If it's low, you'll get the downsides without any benefits. And if I do put you on hormone replacement therapy, it will be natural estradiol and progesterone, not this man-made stuff, and I'll give you fish oils and antioxidants, things like that to prevent clotting. So that's my position on hormone replacement therapy in women. Whether it's good or bad is a function of your LPA. Not all women are the same, so we have to treat you differently based on your unique biochemistry. Bricks, wood, and mortar. It takes more than one problem to build a plaque, just as you need bricks, wood, and mortar to build a house. 818 subjects, 338 with early onset coronary disease, 480 healthy controls, look at standard risk factors, calculate relative risk parameters, correlate standard risks with your LPA. Your relative risk of coronary disease rises if you got high blood pressure, diabetes, smoking, if you're a man, and if you got a high LPA. Relative risk versus the LPA quintile, if you're in the upper quintile, above 44, you're 70% more likely to have trouble than somebody with a low level. We've already established that. Now let's look for interactions between LPA and the other risk factors. Here, if your blood pressure is normal, you got a low LPA below 50, you got a low risk. But if your blood pressure is normal, you have a high LPA, your risk rises. If your LPA is low and you develop high blood pressure, your risk is greater than low blood pressure. But if you got a high LPA and high blood pressure, they are synergizing and your risk skyrockets. Same situation with smoking. Smoking is more of a problem if you have a high LPA. LPA is more of a problem if you smoke. Diabetes is such a powerful risk factor that it didn't really matter what your LPA was. Lipoprotein A synergizes with homocysteine, and if you look at high HDL versus low HDL, that will also modify the risk. So if you got a high LPA and other risk factors and your HDL is low, you're at greater risk than if your HDL is high. Many factors play a role in causing cardiovascular disease, so we're going to think not just about HDL or smoking or blood pressure or LPA. We're going to think about all of them because we know they all synergize to build that atherosclerotic house. So what can we do? How can we lower your risk? Lowering LPA is tough because it's under genetic control. What else can we do to lower your risk if you have a high LPA? Well, we can lower your LDL. 146 men with early onset coronary disease randomized to diet plus mevacoristatin cholesterol that blocks cholesterol uptake from the gut, diet and niacin and cholesterol, two other cholesterol-lowering agents, diet and placebo. Over 2.5 years, look at changes in coronary diameter. You do a heart cath before and after, and you look at event rate. Correlate the event rate and change in coronary diameter with whether your lipid-lowering therapy was successful, if you lowered your LDL by 10% or not, and correlate it with your LPA level. Let's look at disease progression over 2.5 years. If your lipoprotein A was below 45 and you didn't do a really good job of lowering your LDL, it didn't fall by 10%, your artery is going to worsen by just below 1%. But if you got a lowish LPA and you did a really good job with your LDL, dropped it by 10% or more, your artery will open up. We want that. Now, if you got a high LPA due to genetic factors or too many trans fats, and you do a lousy job lowering your LDL, you're going to progress by 3%. If you got a high LPA and you really work hard and lower your LDL, you're going to open up. So the need to lower your LDL is a function of your LPA. You got a really high LPA, you really want to lower that LDL, because if not, you're going to progress by 3%. Event rate, similar situation. You got a lowish LPA, below 45, below the 90th percentile, and you do a lousy job lowering your cholesterol, your event rate's 9%. If you do a good job with your cholesterol, it's 3%. If you got a high LPA, you do a lousy job lowering your cholesterol, we know your arteries are worsening, your event rate's 39%. Versus 9% if you lower your LDL. So if you got a high LPA, one of the things I'm going to do is lower your LDL. Because if I lower your LDL, I can attenuate the risk associated with a high LPA. And lowering the LDL is pretty easy. Lowering the LPA is high. We can, there's a preparation called Heart Technology that was basically designed by Linus Pauling. 1 tablespoon gives you 3 grams of vitamin C, lysine and proline, which will prevent the LPA from binding to the vascular wall, carnitine, E, A, coenzyme Q, and stevia as a sweetener. Here we're going to take 8 individuals with high normal to elevated LPA levels, give them Heart Technology about 2 tablespoons a day over 1 to 6 months, and you can see for the group it fell by 68% from 61 to 19. So this is my favorite lipoprotein A lowering therapy. It's the most effective. Vitamin C, in areas of Europe that have a high vitamin C intake, they have a low coronary event rate. Areas of Europe where vitamin C intake is low, they have a lot more heart disease. Vitamin C deficiency produces coronary disease. Here, let's use guinea pigs as guinea pigs. Guinea pigs don't make vitamin C, but they do make ApoA and LPA just like humans, right? A vitamin C deficient diet without, if you want to take a rabbit and cause cardiovascular disease, you have to make them smoke cigarettes or give them a diet rich in oxidized trans fats. Otherwise, rabbits won't develop cardiovascular disease. But in a guinea pig, all you got to do is put them on a low vitamin C diet and they will fill up with plaque. Low vitamin C diet alone. If you give the vitamin C back, the LPA is pulled out and the corneal plaque regresses. Here are animals on a high vitamin C diet. This is a smooth aorta. Here they're on a low vitamin C diet. You don't give them extra cholesterol, they fill up with plaque. If you give them back the vitamin C, they clean up again. Here we have this is the vascular lining. This is the flow area. Guinea pig on a high C diet, everything's nice and smooth. Here's guinea pig on a low C diet. It's full of atherosclerotic plaque. This didn't reproduce well, but here's a human who died of cardiovascular disease. Similar situation to the guinea pig on the low vitamin C diet. Humans and guinea pigs that don't get enough vitamin C are going to fill up with LPA and fill up with plaque. Low coronary C levels are associated with plaque development in humans. If we look at your coronary artery and we measure the amount of vitamin C in the vascular wall at different areas of the artery, in areas where you've got a lot of cholesterol deposited in plaque, we see very low vitamin C. Areas of the arteries that look good, that don't have a lot of plaque, will be rich in vitamin C. There's an inverse relationship between the content of vitamin C and plaque at various points in your arteries. We're going to recommend vitamin C. Vitamin C neutralizes lipoprotein A. It's a great antioxidant. In some studies, vitamin C will lower your total cholesterol level. Here, 1,000 milligrams a day of vitamin C over 3 weeks resulted in an 18% reduction in cholesterol. In analyzing over 200 studies, it is found that the higher the level pre-treatment, the greater will be the fall in cholesterol with vitamin C. Vitamin C raises the good HDL. People taking 300 milligrams a day of vitamin C from diet or supplements had HDL levels 9% higher than those consuming lower levels. Now, for every point that your HDL rises, your risk falls by 3. So a 9% rise in HDL is associated with a 27% decrease in coronary risk. In this study, vitamin C lowered triglycerides by 50 to 70%. It also induced the elaboration of the liver enzymes that metabolize triglycerides. I haven't seen this in my own patients, but it's been reported in the literature. Vitamin C rescues the endothelium in hypertension. We're much more interested in your endothelium than any of these numbers, because the endothelium is really where it's at. We're going to have normal controls on hypertensives with endothelial dysfunction. Subject all to a cold pressor test and do a PET scan, positron emission tomography, which is our best measure of regional heart blood flow. Do it at baseline, following 3,000 milligrams of vitamin C IV, following 2,000 milligrams of vitamin C orally every day for 3 months, or following placebo. Now what they found, vitamin C had no effect on the healthy controls. They were normal. They couldn't get more normal. Placebo had no effects on the hypertensives. But here we're going to look at blood flow to the front of the heart in the hypertensives during their cold pressor test. It falls to 24% of normal without treatment. That's not healthy. If you give them 1 shot of vitamin C IV, they do a little bit better. But if you put them on vitamin C orally for several months, you restore endothelial function. So vitamin C will rescue the endothelium, neutralize the effects of high blood pressure on endothelial function. Vitamin C rescues the endothelium in hyperhomocystinemia. Now what is homocysteine? It's a breakdown product of protein metabolism, specifically methionine, an amino acid. It causes plaque formation. It causes clots in our arteries and veins. It produces endothelial dysfunction. It's associated with an increase of cardiovascular disease and its consequences, rheumatoid arthritis, Alzheimer's, miscarriage. It's bad stuff. Now, levels rise if we take in food that contains the amino acid methionine. Some of the cholesterol-lowering drugs, and I'm not going to give you the names because you'll be upset, will raise your homocysteine. Levels fall with B vitamins, folic acid, and acetylcysteine. Can we neutralize the toxicity of homocysteine with vitamin C? We're going to take 17 healthy volunteers, measure endothelial function at baseline conditions, then when their homocysteines are high. What we're going to do is give you a methionine load, and that will make your homocysteine go up. Then we'll make your homocysteine go up, but we'll give you antioxidant protection by giving you vitamin C, 1,000 milligrams a day for a week. Here's what we find. With placebo, the homocysteine is not really changing. If we give you a methionine test meal, at 2 hours and 4 hours, your homocysteine is going to climb. This is one of the reasons people get into trouble after meals, because your homocysteine level goes up. Now, if we give you methionine and vitamin C, there's no effect. See, vitamin C doesn't lower homocysteine. It doesn't lower homocysteine at all. However, if we look at endothelial function, flow-mediated vasodilatation, you want a high level. Under placebo conditions, nothing happens. If we give you methionine to make your homocysteine go up, and you're a normal person, your endothelial function plummets. That's one of the reasons people have heart attacks after meals. Now, if we give you methionine, make your homocysteine go up, but protect you with vitamin C and antioxidant, even though your homocysteine level went up, your endothelium does not deteriorate. So another reason to take vitamin C 3 times a day with meals. We showed in our first lecture that antioxidants lower C-reactive protein and Pi1, the clotter, which is why we want to take antioxidants with every meals, because foodstuffs, especially trans fats and methionine and sugars, cause all this biochemical havoc, produce the cafe coronary. We can protect ourselves with antioxidants and vitamin C. Vitamin C in post-angioplasty restenosis, I said the Lipoprotein A is a risk factor for restenosis. We can deal with lipoprotein with vitamin C. Will vitamin C help prevent restenosis following balloon angioplasty? 101 patients undergoing angioplasty of 119 narrowings. Right after the angioplasty, randomize them to vitamin C, just 250 milligrams twice a day, or placebo, reevaluate 4 months later. Now, the angioplasty was successful in both groups. The normal vessels were 2.9 millimeters. Before the angioplasty, it's 0.65. After the angioplasty, it's 2.3, so they gained 1 2/3 millimeters. The percent narrowing fell from 78 to 24 in both groups. But 4 months later, after being on placebo or vitamin C, the vessels have narrowed up again, but they narrowed a lot more in the placebo group. They're down to 1.3, it's still 1.7 with vitamin C. The patients who were randomized to vitamin C lost 1/3 of their gain. Those on placebo lost 2/3 of their angioplasty gain. Percent narrowing was 78% before the angioplasty. Right afterwards, it's like 23%. 4 months later, in the placebo patients, it's 56%. It's 41% with vitamin C. The angioplasty rate was 43% with placebo, 24% with vitamin C. The need for repeat angioplasty 4 months out falls from 33% to 14% if you took vitamin C. Wow, fantastic. Think about all the money that was saved. Think about all the agony that was saved if we would give our patients vitamin C. But we don't. Why? Because vitamin C only produces expensive urine. But it's a dramatic benefit here. Vitamin C in contrast nephropathy. When I do your heart cath, the X-ray dye is toxic to the kidneys. Most of the time, it's not a problem, but in some people, if you have baseline kidney dysfunction, the X-ray dye can clog up in the kidneys and damage your kidneys. And the mechanism of damage is free radical stress. And 2 weeks ago, we showed how N-acetylcysteine, an antioxidant, will protect your kidneys from contrast-induced nephropathy, contrast-induced kidney dysfunction. Will vitamin C do the same? 231 patients with high normal to abnormal creatinines undergoing angiography or angioplasty, randomized to receive placebo or 3 grams vitamin C orally 2 hours before the procedure, 2 grams that night, 2 grams the next day. Carry out the procedure, repeat the creatinine days 2 through 5. Acute kidney dysfunction was defined as a rising creatinine of greater than 0.5 milligrams per deciliter or a 25% increase. Now, the creatinine levels in the placebo group rose from 1.36 to 1.5. Not good. They didn't rise as much, 1.46 to 1.52 with vitamin C. Acute kidney dysfunction, like a 25% rise, occurred in 20% on placebo, only half as many, 9.3% on vitamin C. So vitamin C protects the kidney from contrast nephropathy, as does N-acetylcysteine. Probably many antioxidants would be protective here. Vitamin C rescues the endothelium in peripheral vascular disease. In our first lecture, we talked about how if you have lower extremity vascular disease and you exercise to the point of vascular insufficiency and then stop, you're getting ischemia reperfusion injury, you're generating a lot of free radicals that are spilling out into your blood, damaging every artery in your body, damaging your organs and your kidneys. So when claudicators exercise, their antioxidant levels fall, endothelial function deteriorates, their kidneys begin to leak protein. Here we have 41 subjects, 10 healthy controls, 31 with stable claudication, measure endothelial function and T-bars, a measure of oxidative stress. And at baseline, the healthy controls had good endothelial function. They dilate by 13%. The patients with vascular disease are not so good. That's why they have vascular disease. They're at 8%. Now, the normal healthy people could walk 24 minutes on the treadmill. Those with vascular disease, submaximal exercise was 3 minutes. Their maximum was 6 minutes. The change in T-bars. In the healthy controls, the T-bars don't really change. In the claudicators with submaximal exercise, you can see some evidence that free radicals are being generated, overcoming your circulating antioxidants. But if you really push yourself, get ischemia reperfusion injury, it'll skyrocket. What happens to flow-mediated vasodilatation with exercise, which is really what we're interested in? In healthy controls, nothing happens. In those with the vascular patients that exercise slightly, not to the point where they're really hurting, nothing happens. But it falls a lot when they exercise a lot, causing free radical inflammation. Now, what if you give them vitamin C with their exercise? Well, here, if you give a saline control and you run them into the ground, you can see evidence of oxidative stress. If you run them into the ground and give them vitamin C, that's blunted. Change in flow-mediated vasodilatation with saline, it deteriorates with exercise stress. With vitamin C, it does not deteriorate. So you can prevent the endothelium from deteriorating in response to ischemia reperfusion injury in claudicators, and this also tells us that vitamin C will protect the endothelium from any insult where blood flow is deprived. And that's why we've seen that vitamin C decreases your risks of having a problem after open heart surgery. Same basic concept. Vitamin C chelates lead. 75 male smokers in Mexico City measure blood lead levels, then randomized to receive placebo, vitamin C 200 milligrams a day, vitamin C 1,000 milligrams a day. Repeat the blood lead level at 4 weeks. Placebo did nothing. Low-dose vitamin C did nothing. High-dose vitamin C lowers the blood lead level. It's a chelating agent. Vitamin C in hypertension. 39 hypertensives randomized to receive vitamin C 500 milligrams a day or placebo. Placebo did nothing. But with vitamin C, the systolic fell from 155 to 142, the diastolic from 87 to 78. Vitamin C in serial angiography. This study was published before I was born. Many neat things were discovered before I was born, and now that I'm growing up, I'm actually reading these papers. 16 men with lower extremity vascular disease carry out bilateral femoral angiography to define the volume of plaque in their legs. Then assign 6 to an observation group, 10 get vitamin C, 500 milligrams 3 times a day. You repeat the angiogram 2 to 6 months later. In the observation group, half were unchanged, half worsened, which is what you'd expect. In the vitamin C group, 10% were unchanged, 30% worsened, 60% opened up. This is back in 1945. They showed that oral vitamin C will open up your arteries a little bit. And then we kind of forgot about it. IV vitamin C improves treadmill time. This is a great study. This is the PATCH study, programmed to assess alternative treatment strategies to achieve cardiac health. Actually, it should have been called Programmed to Discredit nutritional medicine strategies to achieve cardiac health. Now, in this study, they screened over 3,000 people. They allowed only 171 to take a qualifying stress test, and out of over 3,000 patients screened, they only took in 84. So here, it's showing they're taking a very select group of patients, not typical of the universe of cardiovascular disease. What are the characteristics of the chosen 84? Well, they had cardiovascular disease, an abnormal angiogram or a prior heart attack. Their symptoms were stable. 95% were asymptomatic or in classes 1 and 2, which meant they didn't get pain until they went more than 2 blocks or 2 flights. These were people who were doing really good and feeling good. Their EKG became abnormal. To be in the study, you had to have an abnormal EKG between 2 and 14 minutes, but for the group, the average was 9 minutes and 40 seconds. Hardly any of my patients with cardiovascular disease can walk over 9 minutes on the treadmill. That's really a good sign. So these people were feeling well, they were doing well, and their stress tests, while abnormal, weren't all that bad. So this is a select group of patients who are doing well, who really can't get much better. You do a baseline stress test and assess maximal oxygen uptake, which is a measure of your aerobic fitness. Now, all subjects received intensive risk factor reduction, lifestyle counseling, a 6-tablet-a-day vitamin mineral supplement, the one that I would prescribe, but which other doctors will not prescribe. Vitamins and minerals and magnesium and folic acid, and active important therapy. Then they received 33 3-hour IV treatments randomized as standard EDTA chelation therapy with 5 grams of vitamin C and 750 milligrams of magnesium, or placebo IV, an inert substance that contained 5,000 milligrams of vitamin C and 750 grams of magnesium. So they're saying that the IV vitamin C and magnesium was a placebo, which of course is asinine. We've just talked for an hour and a half about the benefits of vitamin C. 2 weeks ago, we talked about the benefits of a vitamin mineral supplement. I could talk for hours on the benefits of magnesium. I don't care what your problem is. If you're a cardiovascular patient, you're in the hospital, one of the first things I do is give you IV magnesium. So the placebo group was getting an active therapy. Make no mistake about that. What were the baseline characteristics? Well, those that were randomized to chelation therapy, 50% had had a prior heart attack, only 28% on placebo. The placebo patients were more likely to be on drugs to control their symptoms, and they were more likely to be on a lipid-lowering drug than the chelation patients. So the chelation patients were sicker to begin with, and they were on fewer protective drugs than the placebo patients. Now, what effect did placebo therapy, if you can really call it a placebo, or chelation therapy have? Not much. If you look at the Seattle Angina Questionnaire score, both groups worsened about the same degree. Let's look at event rates, which is really what you're interested in. Well, unstable angina occurred in 9 chelation patients, 6 on placebo. Not a real difference. The only death occurred in the placebo group. 4 of the placebo patients needed angioplasty, and 1 needed bypass. None of the patients on chelation therapy died, needed a revascularization. But because this was a small study, these differences were not statistically significant. Had it been a larger study and you saw the same pattern, it would have been a huge, monumental finding. But because it was a small study, it was ignored. Time to ST segment depression worsened in both groups by about the same. In placebo, they go from 932 to 1026. With chelation, 959 to 1052. I'm sorry, actually, they got better. I'm sorry. They both improved by about a minute, which is pretty good. And cardiac patients typically don't improve spontaneously over time. They improve with active therapy. The VO2 max was about the same. So their conclusion was chelation therapy is worthless. It was no better than a placebo. because both groups improved to about the same degree. Placebo therapy was just as good as chelation therapy. And they published this, and it was used as a criticism of physicians like me. But what does the patch study really tell us? What were the goal of these fine researchers? I think their goal was to disprove a therapy that threatens us, that threatens our wallets. How do you do that? First of all, if you want to disprove or discredit a therapy, first in your study you enroll only patients who can't get much better. Remember, they were all doing well. They could all walk, 9.5 minutes on the treadmill. Hardly any of my patients can walk 9.5 minutes on the treadmill. So they can't get much better. Limit the amount of improvement that you can observe. If you, following chelation or placebo, on your repeat stress test, they limited you to 14 minutes. Some of the patients perhaps could have walked longer, but they just were going to arbitrarily stop at 14 minutes. So we don't know that some of the chelation patients could have gone 17 or 18 minutes. They limited it because they want to limit the potential to show an improvement. Aggressively treat the study endpoints with other drugs. They're all on beta blockers and calcium blockers and lipid-lowering agents. And aggressively treat the atherosclerotic diathesis. Basically, they treated the patients the way I do, with vitamins and minerals, IV vitamin C, IV magnesium, and active therapy. But they call that a placebo, which is a big lie. And they use the active placebo therapy. So really, Patch shows us that our medical system is incredibly closed-minded and biased. We're not as dumb as they think we are. We can see through this. They're not as smart as they think they are, because basically what these guys proved was IV vitamin C and magnesium, along with oral nutritionals, improve your time to ST segment depression by a minute, improve your symptomatic status. So they're basically ratifying everything I'm saying. Now, we can strike back. Ultrasound findings, vitamin C, and 10-year risk. Here we're going to take 10,000 asymptomatic low-risk individuals, just recruit them off the streets, and do an ultrasound. And 80% had a normal wall, 9% had mild thickening, 6% had plaques below 50%, 5% had greater than 50% plaques. You're going to follow them for 10 years. Now, if your vessel was normal, your 10-year event rate is less than 1 in 1,000, or it's 1 in 1,000, and none of them died. You got normal arteries, that's a pretty good sign. If you had wall thickening, none of them died, 9% in an event. Now, if you've got plaques that are visible but below 50%, 2% of you are going to die, 39% are going to have an event. However, if you got an obstructed plaque over 10 years, 11% are going to die, 81% are going to have an event. So if we're thinking about your 10-year risk, the people with the visible plaque, they're the ones at risk. If your arteries are normal, nothing's going to happen. So we want to work hard on these people because they can benefit from our therapies. So a class 3 or 4 designation, visible plaque or obstructed plaque, is 11% of the asymptomatic population, but accounted for 87% of the events and all the deaths. Now, can we intervene with vitamin C? They did a sub-study here, 855 low-risk asymptomatic individuals, baseline ultrasounds, randomized to vitamin C, 1,000 milligrams a day over 10 years, or placebo. 10 years later, you reevaluate. Now, in people who started with normal arteries, vitamin C had no effect. There was negligible disease progression in the no vitamin C or the vitamin C. Because when you're normal, you're normal. It doesn't really matter what you do. Now, those that had early wall thickening but no visible plaque, those that took vitamin C, 3% progressed to visible plaque. Those who did not take vitamin C, 13% progressed. Those that had less than 50% but significant plaques, those who took vitamin C, 6% progressed to a greater than 50% plaque. Those who did not, 34%. If you start with a 50% or greater plaque and you take vitamin C over 10 years, 21% close or develop a new high-grade narrowing. But if you don't take vitamin C, 2/3 of you are going to progress. So disease progression is blunted by vitamin C. What about event rate? Well, if your arteries are normal, nothing's going to go wrong, whether you take vitamin C or not. Event rate's below 1%. If you had early thickening of the wall and you take vitamin C, you got a 3% 10-year event rate versus 8% without vitamin C. 9% in the entire group that did not take vitamin C, the 10,000 patients. If you've got a less than 50% plaque, your 10-year event rate is going to be 8% on C, 38% without C. And if you got a greater than 50% narrowing, your event rate is 44% without C. It's double that, 82% without vitamin C. So disease progression is blunted, event rate is dramatically blunted, and by the way, 10-year mortality was decreased by 43% with vitamin C. So if anybody wants to say vitamin C only causes expensive urine, they're just plain old wrong. Lowering your death rate by 43% over 10 years just by taking vitamin C for pennies a day, phenomenal. Vitamin C decreases coronary death rate. In men, 300 milligrams a day of vitamin C from food or supplements was associated with a 50% decrease in coronary event rate over 10 years. In women, the risk was reduced by a third, but women were less likely to have heart disease. Vitamin C adds years to your life. Men taking in 150 milligrams a day live 2 years beyond the average. If you're taking 300 milligrams a day, you're going to live 6 years longer. Medicare won't like that. Now, we, the brave cardiologists who care so much about you, we're taking aim at heart disease. It's a war. And you know what? Because we're such great doctors, you can show that death rate from cardiovascular disease has been falling due to our efforts. On the other hand, if you look at industrial production and consumption of vitamin C, it's an inverse relationship. So you're doing a lot better, probably despite our best efforts, because you're taking more vitamin C. As we take in as a society more vitamin C, we're doing better. Vitamin C in post-bypass atrial fib. Bypass surgery causes free radical inflammation. That plays a role in atrial fibrillation. We don't want you to go into atrial fibrillation after open heart surgery, but without therapy, the risks are about 40%. We can give you expensive drugs that will decrease that risk. Let's see what vitamin C might do. Here, 100 sequential patients undergoing bypass at the Cleveland Clinic. First 50 get routine care, second 50 get routine care and vitamin C. 2,000 milligrams the night before surgery, 500 milligrams twice a day for 5 days post-op. The atrial fib rate was 33% following bypass in the placebo patients, which is what you'd expect, only 14% with vitamin C. Atrial fib recurrence post-cardioversion. 41 subjects undergoing electrical cardioversion for atrial fib. Here we give you a bunch of Valium, we knock you out, we shock your chest to try to resynchronize the rhythm. The problem is you may go back into the atrial fib. The atrial fib will recur. Why? Free radical stress and inflammation plays a role. Here we're going to take 41 subjects undergoing cardioversion for atrial fib, measure baseline CRP, which measures inflammation in your white count, randomized to vitamin C 1,000 milligrams 12 hours before the cardioversion, then 500 milligrams twice a year for a week, or placebo, no treatment. Do the cardioversion, reevaluate at a week. The white blood count falls a little bit in the controls. It falls a little bit more with vitamin C. The CRP falls a little bit with the controls. It falls a little bit more, but not a great deal more with vitamin C. So there's less inflammation. Recurrent atrial fib. 40% of the patients in the control group, their atrial fib recurred at a week. Not a good thing. Only 5% of those on vitamin C. So when my patients require cardioversion, they're on vitamin C and they're on fish oils and a bunch of other things that we've talked about before because I don't want them to recur. Vitamin C and aspirin-induced gastric damage. We talked about how essential fatty acids will heal peptic ulcer disease and how aspirin wipes out the prostaglandins we make from essential fatty acids. Let's see if vitamin C can help us. 20 normal, healthy young people. They have a normal EGD, that's an endoscopy, no evidence of H. pylori infection. They avoid alcohol, spicy foods, all meds for 2 weeks. Carry out endoscopies before and after 3-day treatment cycles and measure gastric blood flow, free radical stress, microvascular bleeding. You look at the integrity of the surface lining and vitamin C in the gastric juice. The treatment cycles are placebo twice a day, unbuffered aspirin 400 milligrams, and placebo twice a day for 3 days. Unbuffered aspirin plus vitamin C twice a day. So placebo, aspirin, aspirin, and C. Now, if we look at the vitamin C concentration in the gastric juice, if we supplement with with aspirin alone, it falls. So aspirin seems to be wasting vitamin C. Aspirin and vitamin C, it rectifies the situation. Gastric blood flow is decreased with aspirin alone, but if you take vitamin C, you prevent that vasoconstriction. You'll preserve blood flow to the stomach lining, which is what you want. Markers of free radical stress, malondialdehyde and MPO, bad guys, rise with aspirin, but not with aspirin and vitamin C. The free radical inflammation of aspirin is neutralized. Superoxide dismutase and glutathione peroxidase, those are beneficial antioxidant enzymes, are wasted by wasted by aspirin, but not by aspirin and vitamin C. Blood loss, they measured how much oozing of blood was in the stomach lining. It rose with aspirin, it rose a lot less with vitamin C. So vitamin C will protect your stomach from aspirin toxicity because it's blunting the free radical inflammation, the vasoconstriction. If you look at the status of the gastric lining, there were more erosions, an increase in erosions with aspirin, but there was protection with vitamin C. Vitamin C and nitroglycerin tolerance. When you take a nitro under your tongue, you're giving your body a jolt of nitric oxide. That's the chemical that we want your endothelial cells to make. If we give you long-acting nitroglycerins, we will shut down your endogenous production of nitric oxide, which is deleterious. Instead of nitric oxide, you'll make the free radical superoxide, which is why people who take long-acting nitrates are more likely to have cardiovascular events down the road than people who are treated with other drugs. We'll talk about that at a later lecture. Here we're going to look at nitroglycerin tolerance. When we give you continuous nitroglycerin, you stop making your own nitric oxide, you make the free radical superoxide, it degrades the nitric oxide you're getting from the drug, so we have to keep increasing the dose to get the desired effect. Can we blunt that with vitamin C as an antioxidant? Here we're going to put you on people with heart failure, put them on a nitro drip over 24 hours with placebo or vitamin C. And you can see the vitamin E level falls with placebo because you're generating free radicals that will neutralize, destroy vitamin E. But if you give the nitroglycerin and C, you're blocking free radical stress, you're going to preserve vitamin E. Platelet cyclic GMP, you want that to be high. It keeps your platelets from sticky. The nitro drip will crank it up, but at 18 hours, the effect is lost due to tolerance. But if you give the nitro drip and vitamin C, the benefit is maintained. Pulmonary capillary wedge pressure, that's the blood pressure your lung sees. It's high in heart failure. It makes you short of breath. We want to lower that with therapy. It falls with nitro, but then the effect is lost at 18 hours. The effect is maintained with nitro and vitamin C. So if you take long-acting nitrates, take vitamin C along with it. Arginine is the raw material that we convert to nitric oxide. If we will talk about arginine as a therapy, it's a great idea. So you take arginine, it's converted to nitric oxide, and your blood vessels will dilate a little bit. Free radicals destroy nitric oxide. Vitamin C neutralizes the free radicals. So here you give arginine and vitamin C, your blood vessels dilate a little bit more. Vitamin C absorption, 6 healthy volunteers, 2 hours after oral vitamin C. The baseline level is 46. 2 hours after you take 2 grams, it's 114. 2 hours after 4 grams, it's 197. The more vitamin C you take, the more the level will go up. But we're going to suggest you take your vitamin C in 2 or 3 divided doses, because if you just take 1 dose, it begins to fall off. It's down to nothing at 24 hours. So split your vitamin C up throughout the day. We'll close with a kind of a fun study, orange juice and HDL. 45 healthy volunteers substitute OJ for one of their usual beverages over 4 weeks, 1, 2, or 3 glasses. The vitamin C levels rise the more orange juice you take in. Your triglycerides go up a little bit because this was sugared orange juice. But your HDL level rises by 21% with 3 glasses of orange juice a day, and your HDL to LDL ratio rises. Another study was done recently that I don't have up here, and it showed that if you drink orange juice, especially if it was orange juice fortified with C and E, your blood pressure fell. Why not? My major points: vitamin C deficiency compromising the integrity of the vascular wall and allowing disruption of its surface is the most important underlying cause of atherosclerosis. Lipoprotein A, Mother Nature's artery patching response to vitamin C deficiency, is the initiating major propagating factor in human vascular disease. Lipoprotein A is the long sought after link between cholesterol deposition, atherosclerosis, and abnormal intravascular clotting, thrombosis, the 2 key components of human cardiovascular disease. Lipoprotein A is the white witch. It is the ugly cholesterol. Lipoprotein is your enemy. To beat your enemy, you first must learn about it, try to understand it, understand why it's there, then proceed forward with your new knowledge and overcome it and vanquish it forever. Everybody ought to be taking 1,000 milligrams a day of vitamin C. In those studies, I showed dramatic protection at 1,000 milligrams. If you have advanced cardiovascular disease, if you have a high LPA, I'm going to recommend higher doses, 2,000 to 10,000 milligrams. Get your level measured. It's not measured in the standard lipid panel. You have to ask for it. If it's elevated, lower the level in your risk with C, niacin, testosterone in men, estradiol in women, and deal with your other risk factors. The use of the LPA binders, lysine and proline, makes sense, especially in those with extensive or rapidly progressive coronary disease. I've had a number of patients who are restenosing and not doing well. They're on all the standard drugs. I draw their LPA, it's high. I put them on C, lysine, and proline, and they do great for the next decade. So this really works for me. Keep an open mind as we continue to better understand the causes of atherosclerosis, and with that to develop new ways of preventing, stabilizing, and regressing human cardiovascular disease. And that's all I have to say tonight. Thank you very much for your attention.